Journal Club, 25th September 2019. The image in the New England Journal this week concerns a 70-year-old woman who has a 1-week history of dizziness and a generalized rash. And this rash is dramatic, and it seems to be all over. The history indicates the presence of a viral respiratory infection, or so was believed. And on physical examination, she has this rash all over. And, oh God, I don't know why the answer is already here. And we are offered a differential diagnosis of cutaneous larval migrans, erythema infectiosum, cutis marmorata, cold agglutinin disease, and erythema of igne. Well, cutis marmorata is not incorrect. However, the best answer is cold agglutinin disease, because that would also explain the mechanism how this condition came about. And with cold agglutinins, IgM antibodies that cause erythrocytes to agglutinate when exposed to lower than body temperature is common after certain viral mycoplasmal infections and also some viral infections, and would be the best possible answer. And indeed, that is the correct answer. This woman lives in upstate New York and was exposed to temperatures of -9 degrees Celsius, and then she developed this peculiar skin condition. Now, these cold agglutinins are IgM antibodies. They are associated with mycoplasma infections, also Epstein-Barr virus and rubella. And they may cause no problems if body temperature is normal, but if body temperature decreases by 4 degrees Celsius, which can happen certainly in the extremities, etc., then a hemolytic anemia can occur. And the titers that are available of these antibodies can be tested by a variety of techniques as outlined here. And they should not be confused with cryoglobulins that are something entirely different. Now, cutis marmorata is another term for the skin condition that we would also call livido reticularis, although in this generalized fashion, this was extremely dramatic. Now, generalized livido reticularis can also occur as a congenital condition by shortly after birth, or in adults after a variety of different insults, including cholesterol emboli. Now, visceral larval migrans are basically hookworms that have a different primary host, such as dogs and cats, etc. And if they invade humans, they can't find their way home, and they cause this condition called cutaneous larval migrans. That's not what this woman had. Now, erythema of igne is actually a burn condition where the skin is damaged actually due to local burns, and it can have a variety of manifestations depending upon the clinical circumstances. Now, the first topic in the New England Journal is atrial fibrillation, which is an irregular cardiac rhythm emanating from hundreds of circus movements inside the atria rather than from the sino-atrial node. And this massive direction of impulses across the AV node is transmitted further to the ventricles in a non-predictable fashion. And therefore, the rhythm is not only irregular, but irregularly irregular. And people that have atrial fibrillation have an increased risk for stroke because primarily in the left atrial appendage, thrombi develop, has to do with locally inappropriate NO production and other changes that occurs in the endothelium in this particular tissue, and that can result in stroke. And there's a scale for estimating the risk of stroke for patients with atrial fibrillation, abbreviated the CHAD scale, congestive heart failure, hypertension, age, diabetes, and a history of previous stroke. Then we also have to consider what's the risk that this patient might bleed from the therapy that I am going to apply. And that can be estimated by the so-called HAS-BLED score. Now, what to do with the patients that have coronary disease, stable coronary disease with stent implantation, in terms who also have atrial fibrillation, is not entirely clear. Currently, these patients are generally anticoagulated with fenprocamone or warfarin anticoagulant, and if they have a stent or a coronary disease, they may receive aspirin concomitantly. They may also receive a P2Y12 inhibitor, particularly if their stent has been relatively recently placed. But actually, the best strategy for these patients is not entirely clear. This study was performed in Japan in patients that had stable coronary disease but nevertheless had atrial fibrillation, and they were randomized to a treatment of rivaroxaban at 2 different doses, once daily. One group got rivaroxaban alone. The other group got combination therapy. They got the same doses of rivaroxaban, but they also got either aspirin or clopidogrel or prasugrel or whatever else the doctors wanted to give them. So they got a combination therapy of rivaroxaban plus either aspirin or P2Y12 inhibitors. Both strategies seem acceptable. Probably most physicians would continue to give aspirin and the P2Y12 inhibitor therapy, antiplatelet therapy. Now, the primary endpoint is cardiovascular event or death from any cause, and the primary event occurred less commonly in the patients that got rivaroxaban alone as compared to the combination therapy group. And indeed, major bleeding was more common in the combination therapy group than the rivaroxaban alone group. That means that rivaroxaban won this contest, coming and going, compared to rivaroxaban plus one of these other strategies. Makes the manufacturer, of course, very happy. Differences weren't great, but they were statistically significant, as we can see on the inserts here. So the primary efficacy point was met for the rivaroxaban alone group, and the primary safety endpoint was also met for the rivaroxaban alone group. If we look at various subgroups shown here, there are some various differences here, but on the whole, monotherapy seems better than combination therapy. And if we look within the subgroups analyzed within the safety population, that was also monotherapy also seemed to be better than the combination therapy. So it looks like this non-vitamin K directed anticoagulant therapy that requires less monitoring, is more convenient for the patients, seems to have an advantage compared to other strategies as a sole therapy for patients with atrial fibrillation and coronary disease. Now, the next topic is this polypill issue, and we looked at polypill Iran several weeks ago, where in Iran whole villages were randomized rather than individual patients to either a polypill or placebo, and the Iranian polypill consisted of aspirin, enalapril, atorvastatin, and hydrochlorothiazide. And the study was conducted for over 5 years, and the cardiovascular events were less in the polypill group compared to the placebo group. Well, you know how the Americans feel about Iran. So we have a randomized controlled US trial also looking for efficacy of a polypill strategy But here the endpoint was blood pressure reduction and LDL cholesterol reduction. That means to say surrogate endpoints, again in an underserved population. These were poor black people living in Alabama, and they were randomized to the polypill group or the usual care group. This polypill is a little different. It didn't contain aspirin. Instead, it contained 3 blood pressure lowering elements: amlodipine, losartan, and hydrochlorothiazide, and the lipid lowering element was atorvastatin. So here are the patients, and older patients, and they have hypertension, and they're obese, and 95–97% are African American, and their lipid values are given here, and how destitute they are is even tabulated lower down on this table. Now it looks like the primary endpoint of lowering systolic blood pressure and lowering LDL cholesterol are met, but we know that these agents are efficacious in terms of lowering those issues, but here are the data. So the systolic blood pressure decreased in the polypill group by about 5 to 6 millimeters of mercury, and the LDL cholesterol dropped from 115 down to about 98 in the polypill group compared to the usual care group. And various other interactions were not statistically significant. So the authors tell us that the only expense would have been a co-payment of $3 a day, but since these poor patients only earn $15,000 a year, I'm not quite sure, but I think that they received the polypill gratis, and perhaps that would be a sensible strategy. So this study lasted a year, so we'll be excited to learn what happens in 5 years. The next topic in the New England Journal is nasopharyngeal carcinoma, and here we're talking about squamous cell carcinoma, or Plattenepithelkarzinom in German. These tumors are particularly common in the Far East. In Taiwan, in younger patients, 18% of cancers involves these tumors, and they're associated with Epstein-Barr virus. So the question is what to do. The patients are treated operatively. They're also treated with chemotherapy, cisplatin-based chemotherapy, and they're irradiated. And in this particular study, an additional induction strategy was tested, where the induction chemotherapy group got cisplatin, gemcitabine, which is metabolized to 5-FU, and intensity modulated radiotherapy for 3 cycles before the usual care was continued. And the patients that had usual care got chemoradiotherapy alone. And the primary endpoint in this study was recurrence-free survival. So here are the patients, and there are more than 250 patients, not quite, 250 patients in both the groups. They're mostly men. They have a moderate degree of disability. These tumors are advanced, so that T3 and T4 tumor classification is common, although lymph node metastases are a little more constrained, and their disease stages are given, but the randomization was similar in both groups. And what we see is that in terms of hazard ratios, indeed the primary endpoint of recurrence-free survival seems to have been significantly reduced in the induction chemotherapy group compared to the standard care group, although I think that the magnitude of reduction here is not that impressive in my view. Distant recurrent-free survival also seemed to be improved by the induction chemotherapy group. So if we look at recurrence-free survival, looks like there might be about a 15% difference here. Overall survival is given here. That was not statistically significant. If we look at distant metastases, the Hazard ratio looks acceptable, but I don't see a p-value here, and local regional recurrence-free survival was not significantly different. And if we look at a forest plot of treatment effects on recurrence-free survival within the various subgroups, it looks like the induction chemotherapy group did a little better. And if we look at adverse events, as we can imagine, mucositis was more common in the group that got induction. They got a lot of gemcitabine that is metabolized to 5-FU. Anemia was more common. Nephrotoxic events were more common, although the increase was not massive, but it was nevertheless present. Basically, the bottom line is that the 3-year recurrence-free survival was 85% in the induction group and 76% in the standard care group. So that's a difference of 9% between the groups. The next topic in the New England Journal concerns cytomegalovirus, and you'll remember that this is basically a double-stranded DNA herpes virus. 99% of the humans on the planet have had this virus. And if we look at a biopsy specimen, we see these owl's eyes, changes in the nuclei of these cells, which leads to the virus's name, I assume, of cytomegalovirus. Now, if 99% of us have this virus, then it might be possible that if we're immunosuppressed, or if we receive a transplant and are immunosuppressed, that we might have recurrence of cytomegalovirus. That indeed is a major problem after transplantation of either solid organs or or bone marrow transplantation. And in order to prevent reactivation of cytomegalovirus, a valganciclovir strategy has been implemented. But it's possible that miravivar, which is a benzoimidazole riboside acting agent, might be better than valganciclovir. This hypothesis was tested with various doses of the new agent compared to the of valganciclovir. The new agent is to inhibit CMV replication by inhibiting a specific protein kinase enzyme that's present in the virus. So the outcomes involve confirmed undetectable plasma CMV DNA copies at 3 weeks, and the groups were correspondingly compared. Then side effects were also monitored. And as we see here, the gray line is the valganciclovir group, and indeed, after about 4 weeks of treatment, cumulative probability of having undetectable CMV DNA lies at about 80% in all the various groups. The different doses of maribavir seem to do about the same, and the treatments, the efficacy of these treatments seems similar and not statistically different. There were adverse events. Now, these patients are sick and are at high risk for a number of different reasons, but the most frequent event in the maribavir group was acute graft versus host disease, diarrhea, renal failure, and urinary tract infection. In the valganciclovir group, the most common reported serious adverse event that occurred was bacterial sepsis, and there were instances of death. So there are adverse events with either of these two treatments, but then again, reactivation of CMV also is associated with decreased survival and a variety of problems. Maribavir was associated with dysgeusia. That complaint is an ill taste in the mouth. Mostly these are metallic tastes that these patients develop, and that was also a noted side side effect in the Maribavir group. The review in the New England Journal concerns anemia. We discussed some elements of that last week, but the discussion this week is anemia of inflammation, also what we used to call anemia of chronic disease. A whole host of chronic diseases are associated with anemia. Normocytic, relatively normochromic anemia is the picture that's generally seen, and it's associated with inflammation. Since there's been substantial elucidation of iron metabolism in the last 15 to 20 years, we now have a pretty good handle on how this anemia of chronic disease comes to pass. And anemia of chronic disease involves inflammation. That includes cytokines, particularly IL-1, IL-6, interferon gamma, tumor necrosis factor alpha, other markers of inflammation that adversely affect iron metabolism. In other words, the bone marrow is reprogrammed. And we discussed this issue last week. The major controlling element here is a protein called hepcidin that's released by the liver in response to inflammation. And hepcidin seems to block iron uptake from the gastrointestinal tract, and it also blocks then iron release from stores and its incorporation into blood-forming units within the bone marrow. There are reasons for that. With bacterial infections, bacteria love iron, and this is probably a compensatory protective element that is developed when chronic inflammation is present. The effects of hepcidin then on iron release on iron storing cells, and the release of hepcidin in response to inflammatory stimuli has been earlier discussed, and the effects on colony-forming erythroid units within the bone marrow as a response to these signals is discussed in this review. In other words, the bone marrow is reprogrammed in terms of what its purpose is. There's also approximately a 25% decrease in erythrocyte lifespan in response to the anemia of chronic disease. You'll recall that erythrocyte lifespan is generally 120 days, so that we can expect the erythrocytes under these conditions to live less than 90 days. And the diagnosis is really fairly straightforward. We see here comparing iron deficiency anemia to the anemia of inflammation or chronic disease. Marked differences in mean corpuscular volume, mean corpuscular hemoglobin, reticulocyte hemoglobin content, the percentage of hypochromic erythrocytes, serum transferrin receptor, serum ferritin, serum hepcidin levels. So these markers are markedly different in patients with iron deficiency anemias compared to the anemia of inflammation. So distinguishing these two conditions should not be difficult. Then, is there anything that can be done here? And there are various discussions of perhaps binding the activity of hepcidin by means of hepcidin binders, or hindering the access of hepcidin to its target ferroportin, or antagonizing the signal pathways that stimulate hepcidin are in discussion. These possibilities are listed in a tabular fashion here. Prolyl hydroxylase inhibitors that we discussed last week in two important papers are also under discussion here, and there are preclinical studies involving this possibility to provide treatment for the anemia of chronic disease. Interesting patient in the New England Journal is this woman, 25-year-old, comes in with kind of short of breath, has black blood. That's an arterial blood sample, so we're told. And with co-oximetry, she had an oxygen saturation of 88% while breathing ambient air. And that should not be the case unless you're at about 5,000 feet, which this woman was not. And an additional evaluation through modern blood gas methodology shows that she had a PO2 of 120, but when measured with co-oximetry, the oxygen saturation showed that the saturation was only 67%, and the percentage of methemoglobin was 44%. Methemoglobin shows iron in the +3 state instead of the +2 state, so that the iron in the hemoglobin isn't in a position of binding oxygen, and so the blood stays dark. The woman reported having used a large amount of topical benzocaine because of a toothache. I'm not really that familiar with topical benzocaine, but she must have taken a whole lot of it. To deal with this problem, we want to convert the iron 3+ back to iron 2+, and that can be accomplished by infusing methylene blue. That's what this patient got, and then she was relieved of the condition. Here's the patient from last week that has this proptosis of her left eye, and her eye is left looking downward and outward. So she's down and out. We discussed the possibility of oculomotor palsy last week, but the problem here is the presence of this metastasis resulting in proptosis, and it's shown here. This metastasis was operatively removed, and she did pretty well. The patient of the week in the New England Journal is basically a newborn. Pregnancy was okay, and he had a good APGAR score of 9 at birth, and all that's no problem. Mother and baby went home, but he just fed poorly and has a lot of regurgitation or vomiting, but this is not projectile vomiting. So the mother goes to the pediatrician and complains, and so the pediatrician considers possibly some sort of a intolerance of, I don't really quite understand it either, but the mother was advised to begin breast pumping and fortifying her milk with cow's milk. I might think that would make things worse, but at least the baby doesn't get better and continues to come to the pediatrician. If we look at these growth curves involving head circumference or body length, the baby grows, but he stays in a very lower percentile of development, although all other milestones are okay, and he receives his vaccinations, all that's okay, but he continues to come back with this problem of regurgitation and not really failure to thrive, but failure to grow at a desired rate. The pediatrician considers gastrointestinal reflux disease. I wasn't really aware that was a major problem with newborns, but at any rate, omeprazole is prescribed. Baby doesn't get any better, continues to be evaluated, goes to a gastroenterologist. All of this business spans out over about 14 months. And the discussant here is the pediatrician that discusses this case, discusses the reasons for failure to gain weight, vomiting in infants, differential diagnosis of reflux disease, protein allergies, congenital anomalies, pretty good idea here, recurrent infections, pancreatic or biliary tract disease, increased intracranial pressure. The problem here wasn't projectile vomiting. Endocrine abnormalities, there was no clinical evidence of this, and there was no evidence that the child was being abused. So all of these possibilities were discussed. So no other choices, imaging. So fluoroscopy was done, and this youngster has a constriction in the terminal portion of the esophagus here that we can see here, and also some changes suggestive of a sliding hiatal hernia. So endoscopy is then performed, and here we see this narrowing in this pediatric endoscopy. But after the constriction, the rest of the mucosa seems to be pretty unremarkable without evidence of mucosal tears. So an operation is performed, and this area of hyperplasia here is excised, and an anastomosis is performed. What we learn is that relief of the condition is generally not immediate. It takes a while for, I guess, for these for this esophageal tissue to then again normalize, but that eventually was the case. And at 2 years of age, the infant is gaining adequately, weight adequately on an age-appropriate diet, and all's well that ends well. So this is a case of congenital esophageal stenosis with fibromuscular thickening of the esophagus. Then in the New England Journal, here's some examples why computer games are dangerous. And these 3 teenagers developed ventricular tachycardia after electronic gaming. Bad idea. But it turned, one of them had a mutation in some ryanodine receptor, and another one basically had a long QT interval, and the third youngster hasn't been evaluated as yet. So it looks like these 3 youngsters had reasons to have a ventricular arrhythmia, but the ventricular arrhythmias were triggered by electronic computer games. Another topic in the New England Journal that I'm sure will concern us in the coming weeks is vaping. And this is from the New York Times. At school, everyone vapes and adults are in a crisis mode. Good reason. Here's some examples why vaping might be a bad idea. And here are 4 young patients with sequels after vaping. And the discussion here concerns cannabis oils and concentrates and whatever else is in these awful things, which apparently is not under very good observation by the Food and Drug Agency. What the situation is in Europe, I don't know. Otherwise, I find vaping kind of attractive because at least not tons of cigarette butts end up on the street. I guess he pays your money and takes your choice. Now in the Lancet, the first paper involves hypertension in pregnancy. The guidelines committees suggest either calcium channel blocker, labetalol, or alpha-methyl dopa for these mothers, although a randomized controlled trial to treat these pregnant women with fairly severe hypertension and risk for preeclampsia wasn't available. So this study was done in India, and these pregnant women were enrolled and randomized to these treatments if they had a systolic blood pressure of 160 and a diastolic blood pressure of 110. And indeed, that was the case. They were randomized to nifedipine retard, to labetalol, or to methyl dopa. And we see here the systolic blood pressure 158, 158, 157. Diastolic blood pressure of 109, 108, and 108 in these groups of women, almost 300 in this group, almost 300 in that group, and 301 in the methyl dopa group. So this is the largest randomized controlled trial of treating hypertension in pregnancy to my knowledge. So I gave some information that was present in the methods of this study. How these women were recruited, and how blood pressure was measured, and also how blood pressure was then measured when they came in for delivery, where it was the blood pressure measurements were indeed performed in an adequate, consequential fashion in all 3 groups. Now, unfortunately, we're only confronted with tables in this study, And these tables probably won't help you very much, but blood pressure went down in all the patients to a relatively acceptable fashion. The neonatal outcomes were similar in the three groups. And you're probably wondering also whether or not the babies had to be ventilated, or neonatal death, or septicemia, prematurity, etc. So basically what came out in this study is long-acting nifedipine was best in terms of lowering blood pressure. But also the downside is that the infants born to the mothers that received this particular treatment, low or very low birth weight babies were a bit more common in the nifedipine group compared to the other two groups. The next study in the Lancet involves the risk of stroke in patients that undergo major operations that are older or that have a risk for stroke. Now, these are non-cardiac operations. So these patients were evaluated postoperatively very carefully to see if they had any problems with cerebration after operation, and then they were also subjected to magnetic resonance imaging. So if we look at these patients, mean age 73 years, about half, a little more than half were men, the rest were women, obviously. Previous episodes of hypertension, 64%. Tobacco use, not quite half. Diabetes, about a third. Coronary disease, 15%. So these are older patients that are old and sick. Now the types of operation: orthopedic operations, urological, general surgery, vascular surgery, and then also some patients that had relatively low risk operations were also represented. So what came out is that some of the patients, about 7%, developed an unexpected stroke, which was not necessarily clinically apparent, but was associated with decreased cognition after these operations. As we might expect, increasing age was a risk factor for this. And the other variables that were assessed here were not statistically significant to my knowledge. And if we look at the people that had a covert stroke compared to the people that didn't have a covert stroke, over the next 360 days, although the differences aren't great, but they are statistically significant, those that had a covert stroke were more likely to have a transient ischemic attack or to have a subsequent stroke compared to those patients that didn't have this. So the bottom line is that 7% of older persons that undergo a major operation can be expected to have some sort of covert stroke if you look at them very carefully. And those are also the patients that have postoperative delirium or some problem with cognition postoperatively. Next topic is the new treatment for migraine. And again, it involves calcitonin gene-related peptide signaling. The peptide binds on a G protein coupled receptor, and with this we can cure practically everything. The focus in the moment is on migraine, but cardioprotection, antihypertensive effects, and renal protection will surely follow. And in this particular study, the patients were randomized to this antibody or placebo, and the antibody actually binds to the peptide. The study was multicentric in nature. These were migraine patients who were well documented as being resistant to the usual treatments that are given to migraine. And if we look at these patients, a lot of patients, 279 in the placebo group, and 276 got the antibody quarterly. That means that this isn't a treatment that has to be taken every day. And another 283 received monthly injections of this antibody. So this might be a fairly acceptable treatment in terms of prophylaxis if it only has to be given 4 times a year. And if we look here, The change in baseline on the number of migraine days plummets in the two antibody groups, even in the patients that only need this once a quarter compared to the patients that get this once a month. And so comparing this to placebo, this looks like a positive result for this calcitonin gene-related peptide signaling blockade strategy. So this looks fairly promising, and in terms of adverse events, injection site erythema and these kinds of things, we would expect for them to occur. So this looks like another example of, this antibody has now been approved in the United States as far as I know, another strategy for people with refractory migraine. Then the next study involves patients that survive cancer and their risk of subsequently developing cardiovascular disease. Now we know that patients that get anthracyclines and patients that get HER2 inhibitors and patients that receive thoracic irradiation, they have an increased risk of various cardiovascular diseases. But what was inspected here was a whole host of different cancers, and yes, a greater risk seems to be the case. Coronary disease, arrhythmia, yes, but a clear pattern of some particular tumor having a much greater degree of risk isn't evident here. But having cancer does increase your risk of cardiovascular disease should you survive your cancer, which a lot of patients nowadays do. And the tumors differ in terms of their propensity of providing a risk for cardiovascular disease. And if you're an expert in this, you can inspect these tables on your own. Venous thromboembolism, the risk of venous thromboembolism after being a cancer survivor, we would expect that to be greater, and that was also the case for a whole variety of malignant tumors. Pericarditis, not just in those people that get irradiated, that's also more common in the cancer survivors. Valvular heart disease, previous migraine, that really wasn't very different. Thank goodness something wasn't different. But here, venous thromboembolism, heart failure, cardiomyopathy, and particularly here, breast cancer, we might imagine that these risk factors are greater and that clinicians should look out for these as graphically illustrated here. Here's a lengthy table on these various things. So the added value, survivors of most site-specific cancers had increased risk of one or more cardiovascular disease outcomes. I guess that's not surprising. Take-home message, venous thromboembolism was particularly prominent, but I think that we know that these malignant diseases are associated with an increased risk of thromboembolism, and so physicians have to keep that in mind. Now, the review in the Lancet was eliminating malaria within a generation. I think we're all in favor of that. And the executive summary, which extends over 2 pages, discusses a whole variety of operational obstacles and what the investigators believe ought to be done. They suggest that $2 billion a year is going to be necessary to eliminate malaria in the ensuing generation, which presumably will take 20 years. And we know where the action is, where the emphasis has to be. What the authors never mention is some of the innate obstacles here, the fact that most of these countries have governments that are totalitarian and extractive, or that involve rampant participation by drug cartels, or that massive increase in population growth also occurs concomitantly, is not mentioned by the discussants, but I guess they can't mention everything. So here are the countries that require the most attention. Here are the parts, areas on the planet that are particularly in need, and the prevalence of the condition as is, and what could possibly be achieved with the appropriate prophylactic measures, and there are a whole variety. It goes above and beyond mosquito netting, obviously, and all of these innovative strategies and potential threats of urban malaria are discussed in great detail in this review, although the major social obstacles, in my view, are not mentioned because they're politically not correct. So I'm all in favor of highly efficacious, long-lasting vaccines, and perhaps by 2030, something like that will be available. And then hopefully the conditions will be on a downward trend. The estimates, government out of pocket by the patients, how much the governments expend, how much development assistance programs, which makes up the bulk of the funding for this sort of thing, and what would be necessary in the future, the authors already emphasized in their executive summary. So then the last clinical issue in the Lancet is this 66-year-old person that comes in, goes to an eye doctor because he has difficulty seeing. He went to an eye doctor before with the same problem and had his cataracts fixed, which didn't help too much. So on examination, he seems to have some sort of form of cortical blindness and only scores 25 of 30 points on the mini-mental status examination. And his magnetic resonance imaging shows this marked degenerative process involving both occipital lobes, which would explain his problems with cortical blindness, and also his dementia. Frontal lobes don't look all that great either. This is basically an Alzheimer's disease variant that focuses on the cortical lobes, and there's some details that I've added to the report that are shown in the presentation. So that's it for this week. Thank you for your attention, and if you'd like to hear the same business in German, you can stick around for 13 minutes and we'll play the program again. Thank you very much. Das ist aber ziemlich aufwendig, diesen Kram in 2 Sprachen.